Hello everyone. Today we'll be talking about various oxygen delivery devices, including the nasal cannula and high flow cannula and some masks. So every one of you would be familiar with this table. This table tells you which device can give you how much FiO2. However, there are a lot of assumptions made in making this table, which everybody needs to be aware of. You have a normal inspiratory flow rate around 20 liters per minute, and that 20 liters per minute comes from air, which has 20% oxygen. So let's give 1 liter per minute via nasal cannula. Now during inspiration, this patient is getting 1 liter of 100% oxygen from the nasal cannula, while 19 liter, that is 20 minus 1, is still coming from the air. So in fact, there is some portion of the inhaled air that is pure oxygen, and the big part is still the air. You can calculate the percentage of oxygen in this tidal volume by figuring out total oxygen levels and divide by total air, that's your tidal volume. So in this case, your fraction of oxygen is 100%, that is 1. 1 out of 20 liters per minute is coming from the nasal cannula, and that is 1/20th of the 500. While from the air, you're getting around 19 out of 20 out of 500, but the proportion of oxygen is only 0.2. And this is the total amount of oxygen. And when it's divided by the tidal volume, you get a percentage, which is 24%. So if you give somebody 1 liter nasal cannula, you are in fact giving him 24% FiO2. Let's increase this flow rate to 2 liters per minute and see what happens. Now, instead of 19, 18 liters per minute are coming from the air. That is 20 minus 2. Now, as you can see, the amount of 100% oxygen is more in the total tidal volume, and you can similarly calculate it. Here, the fraction of oxygen is 28%. So, 2 liter nasal cannula can give you 28% FiO2. So you have heard about this general rule that there is an increase in 4% for every 1 liter per minute increase. However, we have made an assumption that patient was breathing normally. So we know that normal flow rate is around 20 liters per minute, but let's take an example of a patient who is breathing much faster and is dyspneic. Now when the patient are in respiratory distress, you have seen that they take higher tidal volumes in a shorter time. You're still giving him a nasal cannula at 1 liter per minute. Now patient was breathing at 60 liters per minute, so around 59 liters per minute are coming from the air, that has 20% oxygen, and only 1 liter is coming from the nasal cannula, which has 100% oxygen. So if you look at this figure, you can see the proportion of oxygen is much smaller now as compared to previous tidal volumes. Now 1 is the percentage of oxygen in the nasal cannula, and patient is getting 1 liter out of 60 liters from the nasal cannula, and your tidal volume is now 1000. And from the air, he's getting 0.2% of oxygen, but he's getting around 59 out of 60 liters from the air, and your volumes were 1000. So when you calculate this, you come to a percentage of 21.3%. What happened? 1 liter nasal cannula is only providing you with 21.3% instead of 24%. Understand that your patient will get lower FiO2 for the same nasal cannula flow if the patient is in respiratory distress, or in other words, his inspiratory flow rates are pretty high. So it's very important to look at this factor when you are giving oxygen to them. So how do you overcome this problem? Well, you can overcome by 2 ways. You can give them high flows from nasal cannula to match their inspiratory flow rate, which happens with high flow cannulas. Secondly, you can create 100% oxygen atmosphere around the nose and mouth. So high flow cannulas can give you higher inspiratory flow rate. So let's take our same example in respiratory distress, whose inspiratory flow rate was 60 liters per minute. And now I am providing him 60 liters per minute via the high flow nasal cannula. So during inspiration, he's getting 100% oxygen from 60 liters, but he is not getting anything from the air now. So you would be able to provide him with 100% oxygen. It's the same calculation, but instead all the flow is coming from the high flow nasal cannula instead of air, which is now 0. You can achieve higher FiO2s pretty easily. However, still the FiO2 delivered to the patient depends on the patient inspiratory flow rates. So if your patient has inspiratory flow rate of say 80 to 100 liters per minute, you will be getting lower FiO2 than you believe. There's another problem, which is the problem of mouth breathing. This is the problem with all the nasal cannulas. In this patient with high flow, he was getting 100% FiO2 using a 60 liter per minute via high flow. However, if the patient starts breathing through the mouth, he's going to breathe in from air, which has 20% oxygen. So he's going to dilute the amount of FiO2 that he's really receiving. And to make the matter worse, the mouth breathing gets more common as your dyspnea worsens. So how can you fix it? Well, you can create a 100% oxygen atmosphere or 10 around your nose and mouth, and when you do that, you can breathe through the mouth and still get 100% oxygen. The commonest thing that we use to achieve high FiO2s is using a non-rebreather mask with bag. A non-rebreather bag has two one-way valves. The first valve opens when you inhale, and when you exhale, another valve that opens in the mask for release of carbon dioxide. So let's understand how a non-rebreather mask with bag can provide you 100% oxygen. So you have a normal tidal volume around 8 cc's per kg, which let's average it out to around 500 cc's. The volume of air in the mask and the bag is around 1000 cc's, and this air in the bag has 100% oxygen because the bag fills during the exhalation. Usually you provide very high flows, typically more than 15 liters per minute from the wall oxygen, which should fill this bag up during exhalation. Let's say you have a patient in respiratory distress and his tidal volume is 1000 cc's and his inspiratory time is 1 second. So during inhalation, the oxygen from the cannula, which is going through the bag, will be able to provide him around 250 cc's if you are at 15 liters per minute, because 15 into 1 second would be equal to 250 cc's, and the rest 750 cc's will come from the 100% oxygen from the bag and mask. However, this is not always the case, and it can provide only up to 60 to 100% FiO2. Let's understand why. So we know that the volume of air in the mask and bag is around 1000 cc's, and air in the bag has 100% oxygen. So if your patient, for example, is taking 1500 cc's tidal volume, your bag would be unable to provide 100% oxygen. If your respiratory rate is so high that the bag is unable to fill during the exhalation and is unable to provide that even 1 liter of oxygen. So if your tidal volumes inhaled by the patient is large, your FiO2 would be much lower. And if the bag fills incompletely during exhalation because of the shorter expiratory time, you will not be able to get 100% oxygen. For example, in this case, if your exhalation time is 1 second, you will only get around 250 cc's will fill in the bag at 15 liters per minute. There are other types of masks that can provide you with more definitive FiO2, though not 100%, but they can provide you more accurate numbers that you can provide your patient. One of them is Venturi mask. Instead of oxygen from the wall that is connected to the mask directly, it goes through the valve called Venturi meter. So Venturi meters come in different color codes, and fortunately all these Venturi meters have numbers written upon them. The first number is how much FiO2 will that produce and how much liters per minute flow you have to give through these valves. If you are giving 15 liters per minute through the green valve, you will be able to generate a 60% FiO2. So in this orange valve, you are giving the flows at 6 liters per minute. The small opening results in very high flows, thus creating negative pressure in this area. The principle lying this is Bernoulli's effect. And once you have negative pressure area, the air from outside is going through these openings, and it's going to dilute the 100% oxygen flow from the cannula that is coming in to achieve a 30% FiO2. Similarly, if you're looking at the red valve, the opening of the valve is much larger, and when you give it 10 liters per minute, you do get negative pressure, but the dilution from the air is much smaller, so you're able to achieve higher FiO2s. So what are the problem with the oxygen masks? Some of the CO2 is rebreathed, thus you can increase the anatomical dead space, and this may increase the PaCO2. FiO2 may not be accurate because it depends upon the tidal volume and your respiratory rate as well. Lastly, the humidifying is suboptimal in oxygen masks. We typically use bubble humidifier, and this is not one of the best ways to give high humidity levels. So we have a better way to provide high humidity and high flow oxygen to these patients, and that is using high flow oxygen meter. We have got a sterile water supply which helps in humidification. We've got an air oxygen blender and a flow meter, and we've got a heated breathing circuit so that the humidified air does not condenses, and this is delivered via nasal cannula. The most important way the high flow oxygen helps is by giving you good amount of humidity to your patients. Dry air, as you know, can cause excessive water loss and worsens the mucociliary clearance, and can cause inflammation and inspissated secretions, which can cause obstruction. A high flow oxygen is more comfortable and gives you very reliable humidification. However, if the flows are very high, you may be breathing some of the atmospheric air which may be dry, and thus reduces the efficacy of the high flows. Also, humidity in the inspired air decreases as you increase the flow rates on the high flow nasal cannula. One of the problem is condensation, and this would typically happen when the ambient temperature is low and heated circuit is not used. As we already discussed, a high flow oxygen can give you more reliable FiO2 if your inspiratory flows are less than 60. High flow oxygen is also very useful in decreasing the anatomical dead space. If you give pretty high flows, you are able to create 100% FiO2, and it can wash out all the CO2 in the upper nasal, oropharynx and oral area, and when you breathe in, you don't rebreathe CO2 in this area. 15 liters per minute, you can reduce the dead space area by 20 cc's. However, at 45 liters per minute of nasal flow, your dead space can be reduced by 50 cc's. Normal dead space is around 150 cc's. However, this still has not shown to improve the PaCO2 in your patients. One of the interesting features that is very attractive for high flow oxygen is that it increases the nasopharyngeal pressures. At 45 liters per minute, you can develop around 2 centimeters of water pressure in your nasopharynx when your mouth is closed. However, if your mouth is open, you are only able to achieve 0.5 centimeters of water. At 60 liters per minute, this pressure can increase to 3 centimeters of water. One of the things to remember in this case is most patients will breathe from the mouth as the respiratory distress increases. So increase in nasopharyngeal pressure might be much lower than what you anticipated. High flow oxygen, because of increasing the nasopharyngeal pressure, have been hypothesized to increase end expiratory lung volume and may aid in recruitment. However, there are very few studies to corroborate this argument. In infants, it has been shown to increase the EELV by increasing the pharyngeal pressures, and it was more in obese patients. High flow oxygen has also been shown to reduce work of breathing, improve dyspnea, decrease oxygen requirements, decrease CO2 production, lowering respiratory rate, and possible lowering minute ventilation. Utility of high flow oxygen is oral suctioning and expectoration can still occur, which cannot be used if the patient is on non-invasive ventilation. Also, airway clearance is also improved because of the heated humidified air that enhances the epithelial mucociliary function. So we have seen that high flow oxygen can help in multiple ways, but does it really helps? In a recent ERS clinical practice guidelines and a Cochrane review, It has been shown that high flow oxygen may or may not reduce intubation rates. As you can see, there is a tendency towards reduction in intubation rate. However, the 95% confidence threshold crosses 1. It may reduce escalation to non-invasive mechanical ventilation as well. However, the impact of high flow oxygen on the gas exchange is pretty small. The PO2 in studies have shown to decrease by 16 millimeters of mercury, while no changes in PaCO2 levels have been reported. There have been no effect on mortality, even in immunocompromised patients. It has been shown to increase the ICU length of stay by 1.97 days, while reduction in the hospital length of stay. So what are the limitations of high flow oxygen? The FiO2s are lower if the inspiratory flow rates of the patient are more than 60 liters per minute. High flow can delay invasive management like mechanical ventilation or non-invasive ventilation. Its ability to unload the respiratory muscles in acute respiratory failure may be lower than provided by non-invasive mechanical ventilation, as it can only achieve 2 to 3 centimeters of nasopharyngeal pressures. The use in COPD exacerbation and heart failure has not been established in high flow oxygen, and non-invasive ventilation is still the primary management. High airflows can sometimes cause nasal mucosal trauma, and certainly you are more limited in your mobility if you are attached to high flow oxygen. So in summary, nasal cannulas increase FiO2 up to 3 to 4% for every 1 liter increased flow, but this can be lower during high inspiratory flow rate. To overcome this, you can use high flow nasal cannulas in patients with higher inspiratory flows. High flow nasal cannulas have certain advantages, including humidity, decreasing anatomical dead space, increasing nasopharyngeal pressures, and being more comfortable. However, if the patient has mouth breathing, masks such as Venturi mask and non-rebreather mask may be more beneficial. These are the references if you want to review. Thank you.